A 74-year-old man with hypertension, obesity, hyperlipidemia, and type 2 diabetes underwent drug-eluting stent placement in the proximal LAD 9 months ago. He's now coming in with several weeks of exertional chest discomfort that resolves with rest. His exam is unremarkable, his EKG is unchanged from baseline. Which of the following is the most likely diagnosis? I'm going to make the argument that it's in-stent restenosis. So today, we're going to talk about a few of the complications after cardiac stent placement. We're going to talk about two primarily. The first is in-stent restenosis. So if this is a cross-sectional image of a coronary artery, imagine that a stent gets placed and over time, a little bit of plaque builds up, sometimes called neoatherosclerosis. And over time, you have sufficient blockage so that blood flow through the artery and oxygen delivery through the artery is minimized, which can then lead to chest pain. Stent thrombosis, on the other hand, is when you have a stent placed and there's an acute thrombus. And so when you juxtapose these two, when we think about how they present, in-stent restenosis is a progressive development of symptoms as the stenosis intensifies, whereas stent thrombosis is really acute, so it's kind of an eruption of symptoms. Some risk factors for ISR are things like type 2 diabetes, whereas for stent thrombosis, it's things like being off of your antiplatelet. In terms of mortality, ISR has a pretty good mortality overall, whereas stent thrombosis does not quite have that. And that kind of reflects the tempo of each disease. We need to also think about the stent type and how that plays a risk in these two disease entities. And so bare metal stents are the type of stents that used to be placed, and they are sometimes placed still. And they're drug-eluting stents. And that's a stent that is coated with a material that really helps mitigate production of endothelial cells on it and also thrombus. So you think of the risk of in-stent restenosis, it's actually rather high in bare metal stents, whereas in DESs, it's rather low. When you look at the risk of stent thrombosis with BMS, it's pretty low on the late side. And the newer DESs are really good at making sure the risk is low early and late. So the idea here is that with the advancement of medicine and the progression of using entirely DESs primarily, the risk of ISR and stent thrombosis is low, but it's still important to know the difference. So when we look at cardiac stent complications, there are really two major ones that I want to talk about here: in-stent restenosis and stent thrombosis. ISR is steady re-narrowing of the vessel, whereas stent thrombosis is acute thrombotic occlusion. Pathophysiologically, it's smooth muscle cell growth that's really promoting this stenosis, whereas in stent thrombosis, it's thrombus formation. The tempo really helps here. 3 to 12 months is typical for ISR, whereas stent thrombosis can be really early all the way to really late. So if someone presents within the first 3 months with sort of symptoms, stent thrombosis should be higher on your differential. The presentation also can differ, where ISR looks like recurrent angina, and stent thrombosis can look like acute coronary syndrome. Again, the prognosis is generally favorable for ISR, but lower for stent thrombosis. Type 2 diabetes, the placement of a bare metal stent, are some risk factors for ISR, whereas premature antiplatelet cessation or lack of adherence leads to stent thrombosis. The diagnosis can be made by angiography for either. There is a special CT that you can get to look for ISR, or you would need to do intravascular imaging, which really helps make the diagnosis. Finally, in terms of management, for ISR, you need to repeat a PCI or maybe in some instances do a CABG, whereas for stent thrombosis, it's PCI with thrombectomy, or you need escalation of your antithrombotics.